Thanks for downloading and welcome to Take Aurally, the podcast from Dream Queen's Medical Centre, Nottingham. In this episode we'll be discussing the child with a non-blanching rash. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospital's NHS Trust. Other trust guidelines may vary. All views and opinions are the speaker's own. Hello, welcome back to Take Aurally, and in this episode we're discussing the child with a non-blanching rash and also having a chat about some viral rashes as well. Yep. Rachel Trix is back with me. Hello, Rachel.
Once again, hello.
Hello. Haven't put you off yet. So, I think this is obviously the thing. Non-blanching rash is that thing like, crushing central chest pain or sudden onset headache. It's those few words that we have in our head and go, oh God, alarm bells start ringing. And so once again, we've got some guidelines here from our trust, yep. And NICE has guidelines as well, because it is so important, and just follow the guidelines and
it is really simple as that. We could do a podcast here.
Follow the guidelines, boom. Would that we were, but you are going to have to suffer with my voice a little bit longer, so I'm going to carry on talking. We're going to talk our way through those guidelines now, and then we're going to have a bit of a chat about some viral rashes as well. And then we'll come back and do a future episode about some other rashes and stuff as well.
I think that will be the plan, yeah. That's good.
Excellent, cool. So you're a senior registrar in paediatric emergency medicine. How often do you think you see a child with a non-blanching rash?
With a non-blanching rash? A lot.
A lot. And parents are programmed to look out for this as well. We all know the Tumblr thing, don't we?
So there's been really good public education programs, and people talk about the glass test. I pressed on it with a glass and it didn't disappear. And unfortunately, despite really good immunisation programs, which we now have in this country, meningococcal disease still exists, and it's still one of the leading killers of children worldwide. So it's definitely something that we need to be aware of, and we need to act on if we are concerned.
Because that's what we're worried about, isn't it? Meningococcal disease is the thing. Meningococcal septicemia that we see those cases of, and things that get into the media, and children with amputated limbs, etc.
Yes, and I've seen a few cases in my lifetime. It's definitely something which is out there and we need to be aware of. I think one of the things that we do need to remember though is it gets so drummed into us that non-blanching rash equals meningococcal disease, is that actually only less than 10% of all non-blanching rashes are due to meningococcal disease. So there are a lot of kids out there who have non-blanching rashes who don't have meningococcal disease and don't have serious bacterial infection. However, being able to tell the difference between those two at that very late stage is difficult. And that's where we have the guidelines for, so read the guidelines.
So the guideline starts by saying child or young person presenting with a non-blanching rash more than 5 spots in brackets. Yes.
So we've done the glass test, and I think the key thing is that a significant non-blanching rash is not the child who comes with one tiny spot on their chest, because that's probably nothing too much to worry about. I would certainly say don't go looking too hard. If it's a significant rash, you will see it. But at the same time, do strip off your kid. Do make sure you're looking everywhere for this. I've seen kids...
You mentioned it under the socks, Under the
socks, so make sure you are looking for it.
Cool. So now it says, examine for signs of meningitis or meningococcal disease or other serious bacterial infection.
Yes, so we've talked about this sort of both with our fever in the under 5s and the sepsis podcast. So this is looking, is your child in front of you unwell? Do they have a fever to start with? Are they tachycardic? Do they have raised respiratory rate? Do they look mottled? Long capillary fill time? All those things that we talked about in the red flag sepsis features and the red flag in the traffic light symptoms, or even the amber signs in the traffic light symptoms.
Cool.
Any signs of this child being unwell, then that kind of points us down this needs to be treated as meningococcal until proven otherwise.
Cool. And so that's again, like we talked about, lumbar puncture, antibiotics.
So definitely antibiotics. Lumbar punctures in these children, you can potentially hold off because they may well be sort of heading into DIC if they're sick and may have clotting abnormalities. They may not be stable enough for lumbar puncture at the time, but definitely blood cultures, PCRs, antibiotics, fluid resuscitation if need be as your first line.
Cool. getting seniors involved, getting seniors upstairs involved.
Seniors involved, PICU, everything that we talked about previously. Yeah. It's got a few sort of defining criteria again. So one of those being the difference between purpura and petechiae.
Yeah.
So any child who has a purpuric rash with a history of fever, unless you are certain that it is one of a very small group of differentials, including things like HSP, even leukemia, things like that, these children should be treated as meningococcal disease. So purpura equals meningococcal disease, unless there's one of a few differentials for that. And again, we've talked about being unwell with that. So purpura is easy, treated as meningococcal. The slightly harder group is the petechial rashes. So these are the less than 2 millimeters, often widespread. And as you say, is there a history of fever or
is there any fever? So fever with you or fever recorded before you've seen the child?
Yes. So if the answer to that question is no, then generally we can say this child is safe to be discharged home.
Sure.
They can go home, but you do need to give strict advice on when to come back. So rash is spreading, child is becoming unwell, all the things that we've talked about previously.
Cool.
If there is a fever, then it's a matter of looking at where the rash is. So we know that rashes confined to the SVC region are very unlikely to be meningococcal, and often you'll find that there's a mechanical cause of these. So these children have been coughing or vomiting. Often you find them very fine petechiae around the eyes in these children. So these children, again, you can generally, if you're happy that it's purely due to a mechanical cause, then again you can think about discharging them if they look well and you're happy to send them home.
So that's above the nipple line.
Above the nipple lines, yes. You can also get petechiae from other causes. So tight sleeves, sometimes you might notice if you've been holding a child too tight for a cannula that you can get a few petechiae. So if you can see an obvious mechanical cause for the petechiae, then that's another reason why you can sort of say they're probably okay.
Cool. But if it's not confined to the SVC distribution?
If it's not confined to the SVC distribution, then these are your children who need bloods. So it's a sort of typical sepsis unwell child workup. So full blood count, CRP, coagulation, blood culture, meningococcal PCRs, blood gases, glucose, just to get all the information.
Cool.
And then we are quite sort of literal. If a child looks well and they have a normal CRP and a normal white cell count, then they can be discharged as well.
With all the usual advice.
With all our usual advice.
Yeah. Cool.
But if either of those is raised, then we should be treating them as meningococcal with IV antibiotics and admission.
Cool. That's all very self-explanatory.
It is.
Very good.
I think it's worth mentioning. There's a couple of the NICE guidance out there is really good.
Yep.
And that's what a lot of algorithms are there. There's a couple of other algorithms which are quite similar. There's one called the Newcastle, Birmingham, Liverpool, which is very similar. It's just slight differences in how it defines an unwell child. And then one of the important things that they're doing at the moment is what we call what they're calling the PIC study. Which is just looking at the outcome of children who are presenting with petechial rashes, and we're involved in that here in Nottingham. So if you do find a child with petechial rash, then it's worth speaking to our research nurses about that.
Sure.
The argument is a lot of our current evidence out there is from a pre-immunisation era. So actually, do we need to look at how we're managing things now post-immunisation and see how children are being diagnosed?
Cool. Vaccines work and they cause adults.
Yeah, adults, it's not a good thing.
Vaccines work, that is our message. Good. And so, I mean, the guidance goes through some other differentials. I mean, we're going to talk about other rashes in a later podcast as well. It also mentions non-accidental injury as a potential cause of a petechial rash as well. I mean, we've already done a podcast on NAI. We've done 2 podcasts on NAI, so I'd go have a look in that one as well. But then obviously, once we've ruled out sepsis, and to make sure that is always going through our mind as well.
Exactly, yeah. It should be going through every child you see. You should always have that in your mind.
Yeah, absolutely. Every child. Awesome. So that's our non-blanching rash. Is that we've pretty much sorted with?
Yeah, pretty much sorted that.
So we're now just going to take a slight detour, and I'm going to talk about viral rashes. So we already mentioned in other previous podcasts as well, kids get viruses, and viruses can cause rashes, and I think these certainly patients with strange rashes is my most common cause of Googling, trying to describe it and having a look and go, does that look a little bit like what I've got in front of me? So shall we just talk a bit about viral rashes now?
And I think this leads on nicely from the petechial rash, in that can be caused by viruses as well. So I find it really useful to have a 2x2 table in front of me when I'm trying to explain rashes to people, and I think if you label your 2 columns, what scares us and what doesn't scare us.
Cool.
And then label your rows, what we know the name of and what we don't know the name of.
Cool.
And I think if you start to think through the different rashes which are caused by different diseases, you'll start to be able to find that a lot of them can fit into those boxes. There's very few which fit into the I don't know but it worries me.
Cool.
But
that's reassuring to know.
But if it does, it still worries you, so you can keep this child in. So sort of in the terms of it worries me and I know the name of, that's our pure things like that. And then we can take it from there. So when you've got a child with a viral rash, I think it's really good to just think about your history and think about your examination, because they actually give you a lot of the answers. And if you don't get the answer, it's probably a non-specific viral rash.
Cool. Fair enough.
So obviously, how old is the child? Describe the rash. So what does it look like? We know that depending on what's the cause, it might start in different places in the body, and the spread of the rash will change. And the rash itself may change, and that often gives us some quite good clues. What's the child like in themselves? Are they unwell? Have they had certain prodromes? Are they immunised? What have they been exposed to recently? And then it's always important just to check their immune status. Another question is consider travel, geographic locations. People do move around, but we probably won't be covering the rare and wonderful today.
No, thank goodness. Do parents still send their kids to chickenpox parties? That used to, when I was little, I don't think I was ever sent to one, but I remember like, oh, such and such has got chickenpox, go send your kids to play with them and then they'll get chickenpox over and done with.
I'm not a parent myself, I couldn't answer that question, but not that anyone admits to it, I think.
No. Anyway, so shall we, so that's also our history we've got. Shall we just go through some specific rashes?
So I'm going to say the majority of these rashes, the majority of rashes that you will see will unfortunately end up in that I don't know the name of, but I'm not worried about box.
Fair enough.
So that's the important thing to say to parents. Parents often come to you wanting a diagnosis, but actually being able to say, no, this is a non-specific viral rash. I'm happy it doesn't worry me. I don't unfortunately know the name of it or what's causing it, but it's a virus.
Sure.
Your child should get better.
Sure.
Can sometimes be quite reassuring. The majority are this non-specific viral rash, which is often erythematous, it's maculopapular, it's on the trunk, maybe a bit on the arms, and it doesn't seem to bother the children. One of the other rashes that a lot of children get with no specific cause is urticarial rashes. And actually a lot of the urticaria that we see isn't due to allergy, or it's more due to a body's immune response to a virus or something else that triggered it. So the urticarial child, try not to label these children as allergic children. Remember that they may well have a viral infection causing this.
Especially if that then means that the parents cut out a whole load of food because it must be the milk or something.
Potentially
risk them getting.
Do remember that.
Cool.
So going through some of the sort of more common ones.
I think that, sorry, just go back. I think that might also be when you talk to patients. My mum has told me since I was a little baby I'm allergic to penicillin or something, and actually was it that you had a viral rash?
Viral rash, exactly.
That has been mislabeled, and you've gone your whole life. Not getting penicillin when you could have had penicillin.
And I know there's actually a lot of work being done now to try and delabel children from penicillin allergies, so look out for that going on around you.
Cool. Anyway, some specific rashes,
we'll start with chickenpox. It's probably one of the most common ones that we see. It's also one of the easiest to diagnose. It often starts, it's generally about a 2-week incubation period, so the exposure might have been some weeks back. And you start to get these little erythematous raised lesions, which then develop into vesicles, and they then start to crust over. What you'll often find is with chickenpox, which is that these lesions are at different stages. So you'll have some of the little erythematous areas, other areas which are vesicles, and other areas which are crusting. The child's generally quite well with chickenpox, although they may have a fever. The important thing to mention if they do have a fever is that we should be avoiding non-steroidals in chickenpox, because there's been links with increased risk of invasive staphylococcal infection with the use of non-steroidals, and that they can get secondary infections. So your unwell child with chickenpox
pneumonia and things like that,
you should be going back to your sort of unwell child guidelines.
Cool.
So although chickenpox is generally okay, it's not harmless.
Irritates the skin.
It irritates the skin. It's itchy. In terms of managing it, antihistamines can help, chamomile lotion can help, but it's just trying to keep them as comfortable as possible.
Is it, I got this wrong, when they crossed over you're no longer infectious?
Yes.
Is that right?
Yes, so children shouldn't be going back to school until all their lesions are crusted, because that is the end of their infectious period. Yes.
And then you can show your crusty lesions off to your friends.
All your friends show and tell.
Kids love that kind of stuff. Cool. So that's chickenpox. What's our next one we're going to talk about?
Another common one that I think we don't probably label as much, but we probably see quite a lot of, is called roseola. And these children often come in. We generally see them before the rash, in fact, because they often will have a few days of really high temperatures, which can sometimes cause febrile seizures. So we often see them at that period, but then actually once the fever subsides, then the rash appears, and that's often starts on the trunk and then goes on to the face.
Sure.
And they'll often have a few lymph nodes and things, but generally these children are quite well, but it's just to point out the fever and the febrile convulsion can sort of point you in the right direction of what this rash is.
Cool.
Parvovirus is another one we see quite commonly. So otherwise known as slap cheek syndrome. And they have bright red cheeks, which makes it nice and easy.
Of course, making sure that they haven't been slapped.
Yes, true. So they'll often start with the slap cheeks, and then a few days later they might develop a rash on their body. They're often unwell with it, sort of temperature, runny noses. The one thing, if you're diagnosing parvovirus, is just to check their child's sort of relationship with anyone who might be pregnant, because parvovirus in pregnancy, if they pick it up, can be known to cause miscarriages.
That's an important one.
So yeah, most people have been exposed at some point in their lives, but it's always just worth making sure.
Sure. And so like general coryzal-y symptoms going along with it. And
a good old sort of upper respiratory tract infection.
Cool.
I think the next ones to mention are probably our measles and our rubella. Now, theoretically, we shouldn't be seeing much of these days. MMR is out there for a reason.
Thank you, Andrew Wakefield.
Most people listening to this are probably too young to remember that.
Okay, Andrew Wakefield, children, was a doctor. He is now struck off because he released a very badly very badly done paper linking the MMR vaccine to autism and GI disturbances. His research was based purely on asking parents of children with autism and GI disturbances, when did you think your child got ill? And they went, oh, it was around the time they got their MMR. And that was about as much research as he did. He also had a lot of money paid to him by a law firm who were suing vaccine people at the time. It got published. It shouldn't have been. And a few people have lost their jobs as a result of it. And he got struck off. But he is now touring America and dating Elle Macpherson, because he is a celebrity of the anti-vaxxer movement.
Oh, that's scary.
That's really scary. And, you know, where he follows, so he goes across America, and all the Make America Great Again brigade follow him, and also follows him is measles. Interesting, but there we go. So that's Andrew Wakefield, children.
Yeah, moving on. So, measles. These children are miserable.
Yes.
They are really miserable, and I think that's one of the first things to say. They'll often start with sort of fever, cough, coryza. They've got conjunctivitis, and then the rash is very particular in that it starts on the head and neck and spreads onto the body, and then the extremities. And the other things that you may be able to see is coptic spots in the mouth.
Yes.
So it's one of those things that you always get told.
little white spots on the inside of the...
Yeah, on the inside of the mouth.
So yeah, coptic spots are these little white spots that are on the inside of the mouth. So if you can get the child to open their mouth and have a look on the inner lining of their cheeks, you'll see them. Cool. Yeah.
So rubella. Generally, actually, these children are quite well, and we don't tend to worry about rubella. They often have a rash which looks similar to measles, but it doesn't really cause the child any problems acutely. Again, the risk with rubella is with pregnant women again, and that's why we vaccinate.
Rubella, also known as German measles.
Yes.
If you're dealing if you're talking about, some people use different terms, don't they? But rubella or German measles. Cool. And as you said, pregnant women risk.
Yeah.
For pregnant women. Yeah. Cool. Yeah.
Sort of one of the other rashes which we often see is hand, foot and mouth. So these kids are slightly off it, bit of fever, bit of prodromal illness. It's caused by the Coxsackie virus, and that causes vesicular lesions on the hands, feet and mouth, funny enough, and groin. They're often on the buttocks as well. But these children are generally asymptomatic. It's one of those diseases which goes round and round at nursery and things, so I'm sure if you've had children then you will see it at some point. We talked about penicillin causing rashes earlier. I think one of the other things to remember is EBV or glandular fever. Although there's not always a rash with EBV itself, some of these children get treated as tonsillitis, and then they get started on amoxicillin or ampicillin, and then they develop a rash as well. So just to be aware, it might be something that you see.
Cool. Anything else you want to talk about?
I think one other thing just to mention is, while we're talking about sort of serious illnesses and viral infections, is the child with eczema who gets infected. So eczema hepaticum, these children are often quite unwell, and it is a medical emergency. It's because they'll need to be treated. The rash itself often is sort of scattered lesions, but they all look the same, and I think that's the clear difference between eczema hepaticum and chickenpox. So in chickenpox they're all at different stages, whereas eczema hepaticum they're all exactly the same, uniform.
Cool.
Sometimes it's so extensive that you can't actually tell what's going on in the rash, but if you look at around the edges you generally get a bit of better picture of what's going on. Looking at it, but these children will need high dose acyclovir and often supportive skincare, probably need admission, and may need ophthalmology review if there's involvement of the eyes as well. So that's important to remember.
So these are children with eczema who've got a superimposed infection into that.
Superimposed herpes infection. So it's always important to remember.
Excellent. Thank you. Is that it? Have we reached our end, do you think?
I think so.
Marvellous.
There's other stuff we could talk about rashes all day.
Rashes all day, you know. Excellent. So I think we'll do another episode on other rashes at another point.
Yeah.
But I think that's well done. We've covered non-blanching rashes and our viral rashes. Thank you so much, Rachel.
You're welcome.
Thank you. Bye-bye, everyone. That was the Take Aurally Non-Blanching Rash and Viral Rash podcast. You can find the blog entry for this podcast and the Take Visually infographic at www.takeaurally.com. Remember, you can find Take Aurally on both Facebook and Twitter, as well as Instagram and YouTube. You can subscribe to Take Aurally on Apple Podcasts, SoundCloud and Spotify. For more information about research and education opportunities with emergency medicine and acute medicine major trauma, you can find NUH Dream on both Facebook and Twitter.